Hello everybody, and welcome back to the fourth and final part of our Exam 3 review series. Today we'll be talking about the parasympathetic nervous system, um, as well as nicotinic receptors. So, as we've kind of discussed in previous videos, or at least alluded to, there's really only two types of parasympathetic receptors. Your most common is by far going to be M3 receptors. However, M2 are also exclusively in the heart. And that's really it. There's also some M1s in the brain. For this class, you'll never really touch on that. You might a little bit for therapeutics when it comes to your GI module, uh, which I know sounds funny, but it regulates like nausea. Um, but you won't need that for this course, so I wouldn't worry too much about that. Um, I wouldn't super worry about this, but M3 receptors are controlled by this IP3 DAG system. These are calcium channels. Um, that's pretty much all there is to say with that. And then M2 are potassium channels. And that's just the kind of receptors. You may get a question, but I sort of doubt it, to be honest. Um, Something else, as I might have alluded to in the previous videos, there are certain chemical substances which can more easily cross the blood-brain barrier than others. And one of the biggest distinguishing factors of this is whether or not these molecules are charged. So something like acetylcholine or methacillin, for example, these will not cross the blood-brain barrier easily because they have a charge on them, this charged nitrogen. However, something like pilocarpine would cross more easily because there's not a charged nitrogen. Um, and you'll probably be asked a question of that nature, but you'll also probably be given structures. So I wouldn't really memorize these specific ions that have and don't have charges. Um, yeah, and then just a few areas where these kind of work are you can see the arterioles and veins are only sympathetic. You might get a question on this. Even though, because if you remember, for example, alpha 1 receptors will constrict vessels and beta 2 will dilate skeletal muscle vessels, um, there's no parasympathetic equivalent. So I'm just going to write no parasympathetic like vessels. So that's a key thing. So if you see like ever vessels are being dilated or constricted in a problem, it's almost never, or well, I should say it is never parasympathetic. It's always going to be a sympathetic, either agonism or antagonism. Everything else, though, for the most part, can be parasympathetic. One other thing to point out is that sweat glands, they will use an acetylcholine receptor. However, they are considered part of the sympathetic nervous system. So that's kind of weird. Whereas before, if you remember, sympathetic was primarily norepinephrine. So just a weird little discrepancy there. Not a big deal though. So just remember that if it's sweating, it's probably a sympathetic response. So a little more on these systems is we have contraction in the pupils due to the M3 receptors. These are really all the eyes. Overall, I think we mentioned this in our eye video. I'll briefly go over it here again though. So essentially, this will increase aqueous humor, M3, as well as constrict pupil. So this is kind of just like a maintenance state for the eye. You wouldn't need this in like a fight or flight, versus like dilation can happen in the iris due to alpha 1, and then we won't have as many secretions due to beta 2s. So the eyes are probably the most complex system you'll learn about in this class in regards to like sympathetic versus parasympathetic, but this is just a summary chart of what the each receptor actually does. So just something to make note of. You probably won't get something that specifically asked, but it's good to know. So like we've been talking about before, muscarinic agonists or parasympathetic agonists, they'll generally increase processes like digestion and secretions. secretion, I can't spell. So what do we use these for? So urinary retention and bowel paralysis, right? This kind of makes sense. We're moving more things through our GI tract. Xerostomia, dry mouth can be treated, producing more saliva. Glaucoma, increasing drainage and production of aqueous humor. Again, goes back to this M3 up here. You're making more. Accommodation, this is something with the eye and the distance you can see. You could technically also use an alpha agonist for accommodation, depending on what the patient needed. But these can be used for that. They can also be used to treat intoxication of antimuscarinic drugs. And you'd use like a direct agonist like atropine for that. Again, this is more of a chart of what we've discussed. So it's pupils will constrict, heart rate will slow, nothing will happen to arteries or veins, at least with parasympathetic control. Bronchi in the lung will constrict, just because we don't need all that airflow. Motility of digestion in the body will increase, and the bladder will promote urination. And also glands in general will be upregulated. Okay, so like I said on the previous slide, I believe I misspoke actually. I called atropine a muscarinic agonist. Atropine is a muscarinic antagonist. So it's very useful in blocking those muscarinic receptors when we have excess acetylcholine. This is atropine right here. You can tell based on the structure that since there's no charge, it actually can cross the blood-brain barrier as well, which is really useful. And some examples of this that you might get on the test are insecticides, nerve gas, and then this mushroom, Amanita muscaria. It's on the slides, or at least they were on Dr. Godelski's slides quite a bit. I'm assuming if questions are used, you might see that. Also, this one's kind of common sense, but cholinesterase inhibitors, right? If cholinesterase is being inhibited, that means there's more acetylcholine, so atropine would kind of work against that, blocking those acetylcholine receptors. And then some symptoms of anticholinergic poisoning. They're basically what you kind of expect, right? You would have, and this would be for antagonist, or these are symptoms of like an antagonist poisoning, not an agonist, because these are kind of the opposite of what you'd expect from an agonist, right? If your airways will dilate, that's more, it's either like a sympathetic agonist or a parasympathetic antagonist. Same with high heart rate, reduced secretions. And also, sweat is like a key one here, because if you remember, sweat is like a sympathetic response. So you'd be able to differentiate if it's sympathetic versus parasympathetic based on that symptom. But reduced secretion is also like adrenergic. Yeah, and mydriasis, right? People's dilating, that's also sympathetic. And then these are side effects of muscarinic antagonist. Again, pretty similar to what we talked about over here. CNS effects, I'll just talk about a little bit more since I didn't talk about it right here, but these kind of are in both. You can see things like hallucinations. You can have like respiratory depression, convulsions. You might have heard of people abusing OTC Benadryl, which is a muscarinic antagonist. And hallucinations, right, slowed breathing rates, and even death. That's a pretty common example of that. Tachycardia, delirium as well. Dry mouth, remember, with a muscarinic antagonist, you're having less of those secretions. And since these are antagonists, right, they can be treated with an acetylcholinesterase inhibitor, and this makes sense because that would cause there to be more acetylcholine just hanging around, which would work against that antagonist to essentially retarget those receptors to increase those secretions again, to slow the heart rate, to constrict the lungs. Okay, so now let's dive a little more in depth to acetylcholinesterase inhibitors. We've been alluding to these on previous slides, but I wanted to go a little more in depth just so you had some info on them. So if you recall from our neurotransmission video, Acetylcholinesterase is the essentially only enzyme that will break down acetylcholine. So what would happen if these were inhibited by an inhibitor? Well, acetylcholinesterase would be downregulated, meaning acetylcholine would go up, meaning we'd have more muscarinic effects or parasympathetic effects. So there's a few classes of these drugs. The most common you're going to see are the stigmines. These are your carbamic esters. And there's a few others, such as the organophosphates. Malathion is probably the main one. You can see also, similar to other drugs we've been looking at, some of these will have positively charged nitrogens, dictating whether or not they would cross the blood-brain barrier. Probably the most common you're going to see are physostigmine, the most commonly used today. You might also see something like donepezil, used for treatment of Alzheimer's. We've alluded to that. Oh, and it's right there too. Perfect. Uses for these are kind of niche, but myasthenia gravis, toxicity of that was in a few of your slides, so I might expect to see that on the exam. Glaucoma we talked about back in the eye video, and then Alzheimer's, as I just mentioned. The final and probably most confusing topic in this whole exam is, at least in my opinion, are nicotinic receptors. Um, so something to note about nicotinic receptors before we get into anything is that they will respond to acetylcholine, right? Similar to muscarinic receptors, which is kind of why they got grouped together in the lectures. However, they're not muscarinic receptors themselves. They're kind of like a neutral party. What they do is they're located in ganglia, in like our spinal cord, or wherever else ganglia may be, but it's very typically our spinal cord. And essentially, these are like the points where our two nerves meet up with each other, right? Because all this time when we've been talking about sympathetic and parasympathetic, um, we've been discussing a little bit about preganglionic and postganglionic. Not so much in this lecture, but definitely more in the sympathetic lecture. I know we touched on it. Um, so if we were to block a nicotinic receptor somehow, we would essentially reverse the effect. So for example, if we were to block the sympathetic ganglia right here on this nicotinic receptor, it would have a parasympathetic-like effect. Um, that's not really the best word for it because, right, these effects themselves aren't necessarily linked to these. But while a sympathetic effect would typically include something like high heart rate, high blood pressure, um, bronchioles being dilated, uh, antagonizing that receptor would cause the opposite. So you'd have low heart rate, constricted bronchioles, lower blood pressure. Because remember, those vessels themselves won't dilate due to parasympathetic action. They just won't, constrict. What do these receptors look like? Well, they're pentameters. They're basically just 5 proteins grouped together, and they will usually form either a potassium channel or a calcium channel, with these receptors being grouped this way. But that's not incredibly important. Something else to note is that nicotine can also stimulate these receptors as well as acetylcholine. Uh, Nicotine itself is interesting because it actually stimulates epinephrine release. And if you remember, epinephrine, norepinephrine are sympathetic agonists. So on top of having this ganglionic effect, which is primarily what you're going to want to know for this exam, just be aware they also do stimulate epinephrine, right? So that's why something like nicotine can raise your blood pressure, it can raise your heart rate. So just something to kind of note there. Nicotine also, on top of enhancing epinephrine, will also enhance dopamine. We haven't really talked about dopamine too much in the context of PPI, just because you don't really need it yet. But you might know dopamine is like kind of the reward hormone in your brain, right? Dopamine is good. It usually indicates like just positive feelings, like a positive brain circuit. And that's why something like smoking nicotine can be so hard to quit, right? Because you're literally rewiring your brain to not be rewarded, to feel bad. So we have a couple drugs that are prescription only that can kind of go against this withdrawal from nicotine. You have varenicline. This is a partial agonist of dopamine receptors, and this will essentially prevent nicotine withdrawal, so it kind of gives you some of the reward. Bupropion is the other one. It is an antagonist, and it's also a dopamine reuptake inhibitor. So this will essentially be a little bit stronger generally. Bupropion has a black box warning for like mental health, like suicidal ideation or anxiety. Um, so just something to note when you're selecting these products for patients. But you will essentially get um, blocking of nicotinic receptors with varenicline. And since we remember when we talked about reuptake inhibitors, bupropion will actually enhance some more dopamine being in the brain, so it's almost like you're getting a reward for stopping smoking, which is kind of interesting in my opinion. Um, so I would just remember that varenicline is just a partial agonist, whereas bupropion is an antagonist of the nicotine receptors, but does have some of those dopamine effects to go along with it. And then finally, we alluded to this on the previous slide, but I did want to go to it a little more in depth here, is ganglionic nicotine receptors. Um, this is called depolarizing blockade. Um, when we were to use an agent that would kind of block it, there's two specific types of blockers. There's non-depolarizing. You could think of this as more of just a competitive antagonist, right? This will bind the receptor but not activate it. So you can see there's like no reaction. This gate stays closed. A depolarizing will open the gate, but it also might flood in and overpower the kind of the whole receptor, right? So even though we might have nicotine or acetylcholine at these sites, we have this other substance inhibiting it. And succinylcholine is a very common example of this. Um, there's tubocurarine. To be honest, I had forgotten all about this substance until I made these slides. I don't think that one will be on your exam, but it was on the slides, so I wanted to include it for completeness, even if the pronunciation wasn't perfect. Uh, yeah, so essentially, like I mentioned before, flipping these receptors will essentially flip the response. Um, Something to note also is, remember there's no real reverse for sweating, similar to how there's no real reverse for vasoconstriction. So if you were to flip a ganglionic blockade, you wouldn't really sweat, but that's kind of getting into the weeds a little bit. I would just more know that parasympathetic-like effects, if the ganglion is blocked, they're going to be switched to be more sympathetic, right? Higher heart rate, higher blood pressure, and vice versa, right? A sympathetic effect will become more parasympathetic, lower heart rate, lower blood pressure. Um, and then this is kind of, there's another concept called tone. Um, and this is essentially what will typically this is kind of the resting state of what your organs are generally in. And when you flip the blockade, they'll essentially be the opposite, right? So veins and arteries, remember, are like sympathetic. There's not really an equivalent, but if you flip the blockade, they'll be off, so it'll kind of be turned. And it's something else to note is that it's really only veins and arteries that by default have sympathetic tone. Everything else is going to be parasympathetic by default. So I would definitely know that. That will probably be a question. So when it comes to like your eyes, your digestive tract, right? Uh, Everything else is parasympathetic. But I think that's all I have. So thank you so much for watching and good luck with your upcoming exam.